Let us now start with the expose by Giacomo Vivanti, and who is associate professor at Drexel Autisme Institute at the University of Philadelphia. And he is in charge of detection and early intervention. I am very happy today I was lucky enough to be in contact with Giacomo, with letters, with emails, and he welcomed my request for translation of his work, the work which is the main author of, so I was lucky to translate. He was really nice. He helped me plead the cause with the American publisher, who was very, very greedy. So we got the prices a little bit down for this to be accessible in France. So here he's got his French sample. And this is on the ESDM programs. And we are going to try to, circulate this in childcare centers. Try to disseminate this practice, and this will help a lot the children and their parents. So let me now hand over. You may buy this from libraries, and we still have a few copies available here. So it's predict and improve results with children with NDD with an early intervention. Hello all. I would like to thank Bernadette Roger and ARAPI for inviting me, for the immense privilege of being here and present my research. Unfortunately, my French is not up there yet. It's horrible, so I will continue in French. I'm sorry for you.
So today I'm going to talk about some research that I did with my colleagues at the Drexel Autisme Institute in Philadelphia. We are trying to use a public health approach to improve the outcomes of young children on the autism spectrum, and we do so by thinking about research that can be influential for policy. First of all, I need to disclose some conflicts of interest. I do receive royalties for the book that Bernadette Roger has translated, and another book. Those books talk about some of the interventions that I will talk about today. So this is a very exciting time for early intervention research. What you're seeing here is the amount of research that has been published on the topic of early intervention. And what you can see here is that there is more knowledge that came out on early intervention in the past 3 years than in the previous 4 decades combined. You can see the growth. Now it's sort of stalling. We sort of reached a plateau. But this is good news. It's not just the quantity, but also the quality of intervention research that has improved. This is a very important work by our colleagues, Michael Sandbank and Kristen Botema-Boytel and colleagues who basically looked at the outcomes if you combine all of this new knowledge from early intervention research. And what they reported in their latest iteration of this Project A meta-analysis is that 80% of all randomized control trials, this is the most rigorous way to test the effectiveness of an intervention, were published in the past decade. And most of these rigorous tests of intervention effectiveness test a category of interventions that we call naturalistic developmental behavioral interventions, or NDBIs. So what are we seeing in terms of outcomes? So these interventions do not cure autism, do not remove autism, and do not make children on the autism spectrum indistinguishable from children who do not have autism. I think that message related to early intervention is not realistic, and according to many stakeholders, it's not even desirable for early intervention to achieve that. But what they can do is to mitigate disability. That is achievable. That is realistic in many cases. So that's what we want to do, mitigate disability, and the premise for that is that autism, a diagnosis of autism, including profound autism, and I will talk about some specific cases, can and should coexist with a fulfilling life. And what are we talking about is having appropriate physical and mental health and emotional well-being, and self-reliance, self-determination, freedom from distress, opportunities to learn, to do things. And these outcomes are very difficult to capture with our traditional outcome measures that we use, but this is what we're trying to achieve. Despite the change in the amount, in the quantity and quality of research, many, maybe most individuals on the autism spectrum continue to experience preventable adverse outcomes. And that means that they have experiences or they have trajectories that undermine their physical health, their mental health, participation in community opportunities, educational opportunities, social opportunities. And so how do we identify and address factors that contribute to these preventable adverse outcomes? Now, we can think about this as turning points in the life or in the developmental trajectories of children who are already diagnosed. So what I'm talking about here when I'm thinking about adverse outcomes, things that we want to prevent, I'm not talking about the diagnosis, and I'm not even talking about functioning levels. I'm talking about events or opportunities or experiences or services, things that we can use that might bring different children on different trajectories. And when I say this is not about just diagnosis and functioning level, the best way to illustrate this concept is to think about how the combination of individual, family, services and supports, policies, cultural attitudes, all of these things, all of these different layers of factors that whose interplay modifies our outcomes, all of these factors have created different trajectories for my two brothers, who you can see here, my brother Giulio and my brother Michele, who were both diagnosed with autism in my country, in Italy, in the early 90s. These are pictures from 20 years ago, and the reason why I'm showing them is because despite the fact that they're twins, they have a lot of genes in common. Most likely what caused autism to Giulio also caused autism in Michele, and they had the same environment they were exposed to, but they went on very different trajectories. And what you're seeing here, which is going outside, taking a walk, and enjoying walking around our city in Milan, is something that today will be unthinkable for my brother Michele. So things went the right way for my brother Giulio. He's profoundly autistic, meaning he cannot be left alone for 10 minutes without potential safety issues. He needs support with safety, hygiene, all of that. But there are things that he has learned how to do, including going on a bicycle. He never falls from his bicycle. He's very good at that. He enjoys that a lot. And working in a restaurant. He's the only person I know who never broke a plate or a glass doing this job. He's very good at that. And he was the person during COVID who will be very serious about having a mask on. And his brother, Michele, at some point in his mid-20s, started developing seizures. And that changed a lot of his behavior. Now, currently, he doesn't want to walk outside of home because he's afraid he will have an epileptic seizure and will fall. He's constantly fearful and upset and aggressive and self-aggressive. And because of this behavior, no service is willing to work with him. So he's home with my parents, who are 76-year-old. Most of my life is trying to organize private services for him. And the issue there is not, oh no, my parents cannot go to the grocery store. The issue is my parents cannot go to the emergency room where they are attacked by him, or when he needs to go to the emergency room because of self-aggression or because he falls. They cannot go to the emergency room because of my other autistic brothers. So you can see how it's not about the IQ, it's not about the environment. At some point there can be turning points. Now you might think, but this is the seizures, it's not autism. No, it's the interplay of this medical condition with the fact that this person, my dear brother, cannot talk, cannot communicate, and has difficulties understanding what is happening to him. If you have something scary like seizures, but if you can have a conversation about it, then you can think about strategies to deal emotionally and practically with that. So it is about features like communication and language that interact with events that happen in our life. Now, how do we change that? When I'm not busy organizing services for my brothers, I do research on young children to figure out whether there are things that we can do that facilitate having positive outcomes. And I'm going to start talking about individual, family, and services and supports that might facilitate positive trajectories. So one turning point in the life of many children on the autism spectrum is whether they acquire spoken language during preschool years. We know that minimal spoken language by preschool years increases the risk for lifelong disability, self-injury, and aggression. So maybe we can prevent that or we can mitigate that risk. Yes, some individuals on the autism spectrum will acquire spoken language after preschool years, but the majority do not. So this is something we can look at. To look at these kinds of things, you need a lot of data, and to look at a lot of data, you need people to be willing to share their intervention data sets. And this is what we did in 2017, a consortium of researchers who were involved in the implementation and evaluation of early interventions agreed to share their data so that we could look at outcomes for children who received interventions and figured out whether specific interventions or specific factors might help children acquiring spoken language during preschool years. So what we did is to create an aggregate data set that ultimately I would like to be a resource available to anybody who wants to do analysis from this data set that comprises preschoolers who had received at least around 12 months of evidence-based early interventions that had spoken language as a target. And this was done through university-affiliated programs, which is helpful because it tells us, because it gives us a lot of details on what those interventions entailed. And we looked at the prevalence of pre-verbal and minimally verbal children, meaning children who did not use words to generate sentences, who did not acquire spoken language despite receiving intervention that was designed to facilitate the acquisition of spoken language. And these are the different programs that involved one program directed by Kathy Lord, and other programs around, well, not around the world, in the US, in Canada, and in Australia. So it is a sample that is not representative of the global experience of early interventions. But generally speaking, we had these categories. Some of these children received the Early Start Denver model. Some of these children received other types of naturalistic developmental behavioral interventions. Some of these children received early intensive behavioral intervention, that is the standard sort of ABA program. And some received TEACH, which is a sort of an intervention that doesn't fit in any of these other categories. All of these interventions have a sound evidence-based and include programming designed to facilitate the acquisition of spoken language. So at the beginning of the intervention, these preschoolers whose average age at intervention start was 3-year-old. Most of them did not combine words, did not have what we can call generative language. 1/3 of them started their intervention having already word combination. And 1 year later, half of those who were minimally verbal moved to phrase speech, meaning now they could indeed use word combination or phrase speech. Half of them did not move from the spoken language stage where they were initially. So by the end of the intervention, we had the majority of children using spoken language, not just single words, but combining phrases, combining words. This is good outcomes. But these children did not. So what is it about these children? Maybe it's the intervention. The answer is not really. Advancers here are the ones who did advance from being minimally verbal to use phrase speech. And there are no statistically significant differences here. So if you're very passionate about one of these interventions and you believe that it's better than the other interventions, our data do not show that. Pretty much you can expect, based on this, a minimally verbal child to start any of these interventions after 1 year to have a 50-50 chance to stay where they are or move to a better trajectories. Remember, the ones who already had language, they continued to evolve in their spoken language. We're talking about these children who started their intervention being minimally verbal. There are factors that were associated with advancement to phrase speech, and it's easier to understand those if you look at this bar. But basically, children who were more likely to advance in their spoken language were the ones who started their intervention at an earlier age, who moved to use phrase speech, who had better imitation when they started their intervention, lower scores in the ADOS calibrated severity scores, longer intervention duration, better scores in adaptive and cognitive functioning measures when they started, sort of the rich gets richer sort of picture. And counterintuitively, they had less intervention intensity. And I will comment on this later, but what I think is happening here is that you increase the dosage if you see that your child is not making a lot of progress. You put one more session in your schedule. So can we change these factors? I will say the most changeable one is age at intervention start. And to look at the changes that we can achieve with starting intervention at an earlier age, we conducted a randomized controlled trial. This is the name of the project, Connecting the Dots. What we did is we wanted to test whether using something called the MCHAT-RF, which is an autism screener, is going to help decreasing the age at which children can start their intervention. MCHAT-RF is Modified Checklist for Autism in Toddlers, revised with follow-up. It was created by my colleagues Diana Robbins and Deb Fine. And what we did, these are the two arms of this randomized control trial. We randomized half pediatric practices to be trained on this autism screener, and we told them, you're going to screen all children at 18 months in the next 3 years using this autism screening. All of them, not the ones that you already think they might have autism, all of them. The point is it has to be universal. And this is a checklist. You ask some yes or no questions. Does your child make eye contact? Does your child imitate you? And so on. And they saw around 3,000 children during these are the regular patients who come to their pediatric practices during the trial period. And then for half of these pediatric practices, the ones that were randomized to business as usual, they were told, do what you normally do. And many of those practices would use the MCHAT, but they will use it without any sort of monitoring or training or standardization. And so what we found is that the pediatric practices who received the training on using this autism screener, they sent us 186 children. When I say they sent us, they referred them to a diagnostic evaluation that then we offer to those families at no cost for them at the Drexel Autisme Institute. The ones who were not trained, they sent us 39 children. This is a statistically significant difference here. Now, those children who came from the practices who were trained to use the autism screener, they were younger. And the majority of them, they did indeed have autism, 75%. But also the majority of the ones who were sent by the practices who were just referring based on their clinical judgment, did not receive a training on the MCHAT. Most of them, they did have autism. So it's not that they were making bad judgment for the referred children. It's that they were referring fewer children to start with. So by the time they received the diagnosis, these 72 children, because many of those families did not want to do the diagnostic evaluation, and I'm going to comment on that later. So the ones who did want to do it were ready to receive intervention before age 2. Now, it's important to understand that not all children on the autism spectrum are symptomatic by that age. This is a population within the autism spectrum who is diagnosable by this age. And this is more than twice of the children who came from practices who did not receive this training or did not use the MCHAT in a standardized way. And they were also older. And by the way, these children who came from practices that used the MCHAT, they had more variability in terms of verbal functioning, social functioning, and cognitive functioning, meaning that through this arm, we will see children who also included milder presentations of autism or disability. While these children were all in the severe end of the spectrum, meaning when pediatricians were using only their clinical judgment, they were more likely to refer children who had more pronounced impairment. Okay, so that's something we can do. We can change that. We can do the MCHAT. It's not going to capture all children. There are pros and cons, but we believe the benefits outnumbers the risk of using autism screening. What about imitation? Remember, children who have more imitation, they have better chance to learn how to talk. So we can change, we can teach imitation, and that's something that we could do, that we can do. For example, increasing the amount of focus on imitation for children in our programs. And but there are ways to do it that help and other ways that don't help much. Now, let's see if I can play this one. So what you're seeing here is a colleague of mine who's pretty junior who wants to teach this child imitation. But she is stuck with the idea that first this child needs to put away these toys, and after that they're going to be face to face, and she's going to clap hands and tell him, now you do it. And now she's trying to explain it to him. Now we're going to do something else. We're all done with the markers until this child is gone. And at this point, what you're going to see is that this is a very zen child. He's just walking away, but other children could get very frustrated if you're trying to do that. And at the end of this difficult session, this colleague told me, this child, I don't even know if he can imitate because he doesn't even pay attention to me. And that's the point. First, you need to engage the child, and then you can do your imitation trials. So another way to do this is what we do with naturalistic developmental behavioral interventions. You start with something that the child is already doing. You join in, and then you expand what the child is doing through imitation opportunities that are embedded in the child's play. So, can you play this, please? So here, for example, this child really likes to run and jump. It's the same child that you saw before. He likes to run and crash on the floor. And I know that because his mother told me after that session, do something that it has more motor components. So here, this is what you will call an ABC sequence, where I'm providing an antecedent. Child doesn't look, so I'm using a physical prompt. Here, now he knows what we're doing. There's an antecedent, there's a behavior, there's a consequence. Now the next time I'm doing it, I'm gonna do it without any prompt. This is my antecedent. Child is imitating now without prompt. And now I'm going to expand what I'm asking this child to do. And now we're going to jump instead of using our hands. And the important thing here is that this is difficult. This is difficult for this child, but he's not getting frustrated because there is a positive, playful interaction there. And so he's trying. And maybe next time he's going to do it even more. Now, how is this related to language? Can you play this video, please? It is related because the next thing that you ask a child to imitate is not just a motor movement, but a mouth movement. So, for example, with this child, now you're going to see another ABC sequence embedded in her play, antecedent. This is the behavior. And what's important here for this child is that now she's doing this mouth movement. She doesn't talk, but she's doing brrr. And then from there, you expand into using syllables and ultimately language. Now this, you can also teach siblings how to do that because it's fun. And this is what we did in this recent research with my colleagues in New Zealand, because generally speaking, siblings come up with better ideas than their parents when it comes to engage someone that age. But this particular thing that you just saw doesn't work for everybody. Like some children, you're doing that and they still don't talk. And it's important to acknowledge that. The other thing that I want to acknowledge before I forget is that these techniques that are part of the Early Start Denver model, an intervention created by my colleague Sally Rogers, were influenced by the research done by Jacqueline Nadel, who is here in this audience. So thank you for this contribution. Now, some children might need another path to improve their communication, and that is through augmentative alternative communication. And we can start early on. Now, what I'm going to show you now is an eye tracking study where we looked at how different children on the autism spectrum, before they received their intervention, were paying attention to instructions that were delivered using verbal and visual means. The red dot that you're going to see here is where the child is looking at. And these 4 children that you will see are 4 children who each has a diagnosis of autism. Can you please play the top, this video?
I want you to pick up the block and put it in the cup.
You can see that this child on the autism spectrum were looking at the face a little bit and was also looking at the picture. Now look at the different visual pattern of this second child. Can you please play this one?
I want you to pick up the ring and put it in the bag.
He's looking at the pictures but not at the face. Can you please play the bottom left?
I want you to pick up the block and put it in the cup.
This child does indeed look a lot at the face. The way I was doing it when I was learning English, I had to look at people's mouth. I couldn't understand people on the phone. It reminds me a lot of that. He doesn't care about pictures. And then if you can play the last one.
I want you to pick up the keys and put it in the box.
You can see attention to the gestures, but not to the pictures. Now, we did this research because with my colleague David Trembath, who is a speech and language pathologist, and there was a lot of debate in that context of whether you should use pictures because children with autism are visual learners, or whether you should use verbal communication because that creates more social engagement, or gestures. And the reality is that we didn't find a clear autism pattern. We found all of these different ways in which different children with the same diagnosis were learning differently. And this is fine because these are all legitimate way of communicating gestures, pictures, and focusing on someone's mouth. Now, what's important, children who were paying more attention to the face, that was associated with better outcomes in response to the early start Denver model who they received for 1 year after this experiment. And then some children, the ones who were looking more at the pictures, they had a better response to an intervention that was more heavily focused on augmentative, alternative communication. So rather than sort of fighting about my intervention is better than your intervention, what we're seeing here is that different children might have different preferences and styles that could lead them to acquire spoken language, either through this heavily sort of focused on social engagement, face-to-face routine with a lot of eye contact and all of that. For some other children, these types of intervention might facilitate spoken language acquisition, and they're not mutually exclusive whatsoever. So the message here is that we didn't find a single path to these potentially positive outcomes. Now, we talked about aspects related to child, family, and services and supports. Now I want to talk about policies and cultural attitudes, how these interventions are implemented. This is a study that we did when we started delivering the Early Start Denver model as part of one of our trials at our institute in Philadelphia. In the first few months, we had some of our therapists, they were very talented and they were getting it. They were doing it right away at fidelity. When I say fidelity, I'm talking about the degree to which you are using all the prescribed elements of the intervention. So if you're doing all the elements, you are at 100% fidelity. If you're using half of them, you are at 50% fidelity. And so we had some therapists who were really good right away, and some others could not get it, or they were getting it at a different pace. And what we measured was the degree to which children were indeed learning the behavioral targets that we were targeting, and how was that associated with the levels of fidelity. And we found that the more the therapist was implementing the intervention at fidelity, the more learning targets were there. So it's not just being in a program that is evidence-based, but it's also whether the program is indeed delivered as intended, that might contribute to outcomes. Another aspect related to policy is whether it makes sense for these interventions to be delivered in early childhood education settings. I'm an advocate for delivering early interventions in early childhood education settings, daycares and preschools. I find it very difficult when I see a child who goes to daycare during the day, and then after daycare they go to in a therapy room where they're doing intervention on top of that. So what we did for this study, we trained teachers, early childhood education teachers in Australia, which is a context of very high quality early childhood education. And we trained them to deliver the Early Start Denver model in a group setting. This is where this book comes from that experience. And this, the first thing that these teachers asked me is, okay, but should this happen in a regular mainstream setting, meaning an inclusive classroom where you have one or two children with autism and everybody else is typically developing, or should we do it in a sort of specialized setting where all the children have autism? And my answer to that is that I have no idea. We don't have a lot of data. I know the debate about it, but I don't have a lot of empirical foundation for making that decision. So we did a randomized control trials. Children were randomly assigned to receive their intervention in inclusive classrooms or specialized settings. What we found at the group level, it did not make a difference. We saw improvements in both settings. We saw a very positive thing, which is an improvement in the quality of education for the typical children, that the typical children received. So it was helpful for these teachers to learn these techniques because that resulted in a better quality of education for the classroom, for the entire classroom. And in terms of clinical outcomes, we saw results that were very similar or that were non-inferior to those of children with autism who received a one-to-one early intensive behavioral intervention. So this was a group intervention. The ESDM had one adult delivering instruction to 3 or 4 children at the same time in the classroom. And we compared outcomes of children who were in a clinical setting doing one-to-one standard ABA. So at the group level, there were no significant differences, but you see a lot of variability, a lot of variability. So it wasn't as much whether you were doing group ESDM or early intensive behavioral intervention, because within each group, your response to intervention was very variable. And so we looked specifically, now I'm talking about those children who received intervention in a inclusive versus non-inclusive settings. We just asked the question whether some children benefit more from receiving intervention in inclusive versus early childhood education settings. We used, again, eye tracking. Again, we use that when we want to figure out what children look at in response to specific stimuli. And what we found here, the take-home message here is that children who were paying more social attention, whose attention was more on people's faces in response to eye tracking stimuli, had better outcomes in inclusive classrooms, meaning that if they were paying less than 2 seconds attention to a video in which there was a person, their outcomes were not as good into an inclusive setting. What does it mean? It means that even if you're sharing the same physical space with typical children who are supposed to provide models for language and play and so on, if you're not paying attention to them, then you're sharing the same physical space, but you're not sharing any learning experience. So it did matter whether children were more socially, let's say, attentive or curious or more interested in people. That was not the case in the that was not the case in the specialized settings, meaning children's outcomes were not dependent on the degree to which they were paying attention to other people. IQ, or cognitive or developmental functioning, also made a difference, meaning that the nonverbal DQ was associated with outcomes in terms of language for children in the inclusive classrooms. Specifically, those whose nonverbal DQ was below 37, which is very low, did not benefit a lot from being in the inclusive setting, while there was no difference related to cognitive functioning in the specialized settings. So again, it's not whether inclusive settings are good for autism or specialized settings are good for autism. Really, different children might benefit from different settings, and being in a setting that is more appropriate for them can be one of those turning points. So there's more than that. So if let's say that everything is in place for your child to receive an evidence-based program, and that evidence-based program, maybe there's even guidelines and policies to receive it within a public healthcare system. So the difficult thing is that, for example, in my country, there are guidelines that specify that you're supposed to receive evidence-based intervention, and in the United States, in some states, there are specific mandates that say that the child will be reimbursed for receiving, or that the families, but basically that you can access ABA intervention that will be paid by public insurance. So this is great, except that people cannot agree what evidence-based exactly is. There are different agencies that use different methods to establish if something is evidence-based. And they cannot even agree what ABA is, meaning that the intervention that you saw before in the video, it does tick all the boxes for an ABA intervention, because you're teaching behaviors, because you are providing a positive consequence for the specific behaviors that you're designed to teach. But basically, if you want to provide that intervention, you run the risk that it's not going to be acknowledged as an ABA program, and therefore there will then be funding for that. So this is a system-level program, but again, this is a turning point in the life of a child, because if you are in one state versus another state, you might or might not have access to those kinds of interventions. Another turning point is whether decisions that are made about those interventions are influenced by TikTok influencers. And how people perceive the diagnosis and the interventions is increasingly affected by social media influencers. You're familiar with TikTok. It's a social media platform with over 1.7 billion active users. And autism is within the top 10 hashtags for health-related topics. The fact is that autism on TikTok is a different thing from autism as we talk about today. And we know that because we did some research where we painfully went over the top 100 most viewed TikTok videos, and these are the kinds of things that you find. You might be autistic if you have a strong sense of social justice, have ideas that you think are genius, but nobody else seems to think they're genius, often feel confused and overwhelmed, and you like to listen to the same song multiple times. Now, these same people also have influential opinions on intervention, and that can be, don't do that intervention. One thing that I often hear, for example, is imitation is toxic. Don't do interventions that will encourage your child to imitate what another person is doing, because that will encourage camouflaging, that will encourage conformity, that will encourage trauma, and all of that. Now, the point is, we can have a discussion on the pros and cons of encouraging imitation and how. But the way these opinions are conveyed is very, very confident. And so what parents or individuals themselves who might think they have autism are exposed to is someone who very compellingly make a case that will potentially change the life of a child. Because when we take no action, when we decide, I'm not going to have my child doing that intervention, we're making a decision for them. Just like if someone decides not to teach you how to swim or anything else, it's going to have consequences later on. In this research, where my student forced me to watch TikTok videos, and I will hate him forever for that, we found that 70% of content in the top videos associated with the hashtag autism was clearly inaccurate. And some of that content you're already familiar with is vaccines cause autism, and some of it is content where there are absolutely exaggerated, unsophisticated, and unnuanced claims related to diagnostic processes and intervention too. So this is another important point. I'm going to, and the last topic, the last turning point I want to talk about is the prevention of cognitive deterioration. And here I'm talking about adults. And the reason why I'm talking about adults is because we did this research where we showed using insurance claims. These are not individuals that we saw directly, but we analyzed data for individuals who are on basically healthcare, publicly funded healthcare programs where you receive reimbursement based on diagnosis that you might have. And that allows us to see a large group of a population really of Medicaid beneficiaries, people who are benefiting from these insurance programs. And what we found is that in those who had an autism diagnosis, there was a 2.6 increased likelihood to have early onset dementia as a diagnosis that was used as a claim. Again, we didn't see those individuals. And then and the average age was before age 50. So there was some kind of cognitive deterioration that either the patients themselves or their carers indicated as a claim in these programs. For those older than 65, this is a separate data set that uses another medical insurance program. 1 in 3 had Alzheimer's as a claim. And this is much higher than the 1 in 9 in the general population. So I don't know if there is a neurobiological explanation, but what I'm concerned about is the lifestyle of these individuals, because those who did not learn how to talk, they might have, or to communicate in any other way, might have a lifestyle that denies them from social opportunities, cognitive opportunities, any opportunities. And this is, for example, the case of my brothers, because how do you get opportunities when your parents are very old and you live with them? Well, through services. But navigating services is a nearly impossible task. If you're looking, even if you want to unpack all the procedures and processes, and you're asking something simple like, my brother knows how to go on a bike and to work with dishes. Is there any program where that can happen? The answer is usually, well, yes, but you have to do this, and then it doesn't materialize. So this is something that needs to change. I'm going to conclude with saying that to change this state of affairs, to improve outcomes and affirming rights of those on the autism spectrum, we need to move from this idea that we used to have in public health of a linear process where first you discover some phenomena, for example, that some children are responsive to visually conveyed information, and then you test the hypothesis that that strategy helps with their learning, and then you translate that into some kind of service provision and policy. That is not sufficient. We need to use a circular approach. And that means that once your intervention or your program is in the community or has achieved the status of evidence-based intervention, that's just the beginning of it. After that, what you do, you need to keep studying what is happening to the end users who are receiving that program, who are the beneficiaries of that policy. What are their experiences? Is this working for everybody? Is this working for a subgroup? What is it about that subgroup? Sometimes parents ask the very practical questions, like a parent asked me, I'm sorry, but you told me early start Denver model is evidence-based, right? So how come my child doesn't talk yet after 1 year of you doing this? And I have to say, because you are misled into thinking that evidence-based means it's going to work for my child. It does not. That's not what evidence-based means. So we need to be practical, and we need to be clear also, and we need to learn from the questions that our end users ask. So one attempt that we did is to rework some of the concepts that are foundational to the early start Denver model, the early intervention that you saw before, together with a person who I would consider a thought leader in the neurodiversity movement, who had some objections in how this intervention was delivered. And to do that, we had to change not just the procedure, but the entire theoretical infrastructure of this. And this work, we started this work by publishing this paper. And basically what, I'm not going to go into details because my time is up, but basically what we did is to start to reorganize the way we're thinking about practices around the concept of agency and the idea that the construction of new knowledge is based on the idea of the child as an agent. This is the sort of non-negotiable idea there, from child self-initiated behavior and learning through positive interactions that are built on the learner's motivation and goals to promote engagement in novel schemas, novel behavior, through well-calibrated variations on familiar schemas. And that is the idea that will create an interplay of comfort and challenge that will help management of anxiety in the face of novelty. So a lot of these concepts of agency and also anxiety and novelty versus familiarity and comfort that comes from familiarity and challenge that comes from novelty were not in the original constructs informing the early start Denver model. They were very important for the person who we were talking with, so we're trying to incorporate that. Of course, it's not the opinion of just one person, but we need to do this kind of rethinking. So in conclusion, this is an exciting time because knowledge on intervention is advancing at an unprecedented pace, but this knowledge is not readily translating into improved outcomes for all children on the autism spectrum. Some of them are still left behind. And most factors contributing to positive versus suboptimal outcomes are potentially modifiable. And these include age of diagnosis and teaching prerequisite skills and assigning children to interventions and context based on a best fit algorithm, assigning children to interventions that seem to be a good fit with their learning preferences, and also families' interaction style, I will add. And also by addressing the perception that individuals have about autism and the misinformation that people are exposed to. And addressing these factors requires a public health framework that really contextualizes the challenges and opportunities associated with autism, with this idea of cyclical processes of knowledge that uses rigorous science but also end users' experiences, so that we can keep learning and stay humble as we learn more and more. Thank you for your attention.